He really needs no introduction, but he's a true visionary and leader. One of the hardest working person I've ever met in the field of pain management, and a true champion for all of us. Thank you, Dr. Manchkhan.
Thank you, Amol. I hope everybody can hear me. If not, please send me a message or Melinda will control it. Good morning, everyone. For some of you probably are still sleepy, but to accommodate all zones, that is what we have to do. I'm going to do a brief introduction on American Board of Interventional Pain Physicians competency and board certification. No matter how many times we talk about it, people keep questioning about this issue. So here is my disclaimer. I hold several hats, but I wear several hats, hold several positions, but I really don't take any funding from anyone personally. Again, this is our second virtual conference. Thank you. And no shake hands. Let us namaste. Our Indian tradition, it took this many years to learn it for British, but for us, it took only, in America, it took only 5-6 months. Our number one goal at ASIPP and ABIPP is to help you to excel in life, to be number one. How do we do that? That is a hefty goal, specifically in this atmosphere. By improving your clinical skills, by improving technical skills, by providing ABIPP certification, also helping you to understand what is evidence-based medicine and what is not, or evidence-biased medicine, and arming you with appropriate information. If you look at our guidelines and compare with someone else's, you will clearly see the differences. And finally, the bottom line is to preserve the IPM into the future, not for myself or not for yourself alone, but children, grandchildren. This American Board of Interventional Pain Physicians was started as an organization to bridge the gap between theory and practice. It is a specialty board. It also provides board certification and competency certification in IPM. Along with that, it provides competency certification in spinal endoscopic decompression, which is in preparation, regenerative medicine, controlled substance management, controlled coding, billing, compliance, fluoroscopy. So the main purpose is the board certification in IPM. Competency certifications are additional benefits. ABIPP, American Board of Interventional Pain Physicians, as it stands now, is recognized in 13 states either by legislation or through Board of Medical Licensures. In 11 states, it does not require any certification because they do not have any statutes. So once you are certified, you can say that you are certified. In Rhode Island, you need to say it is not an ABMS board. So it is case-by-case determination in Oklahoma. In multiple states, we are working on them: Alaska, Connecticut, Delaware, Idaho. So we are working on a daily basis in these states, but it will be good if we can get local help, like Louisiana. We have a lot of help there. Again, board certification and competency certification are not synonymous. Some people try to claim that they're board certified after taking competency certification. That is not accurate. Diplomate eligibility is that there are 3 pathways to become a ABIPP diplomate. One is certified in the primary specialty, approved board, then have fellowship in an ACGME accredited program or 2 years of non-accredited fellowship. The third path is that or 6 years of full-time teaching and or practice in interventional pain management, plus 300 hours of continuing medical education in pain medicine, of which 50 hours is in cadaver experience with satisfactory completion. Just because you attended a course doesn't mean anything. The other option is that you can use fellowship in a non-ACGME accredited program for 1 year, but then your experience goes down. You need to be experienced only for 3 years and 150 hours of continuing medical education. Also need to have unrestricted license to practice medicine. Eligibility for competency. This is for the folks who do not have primary board certification for various reasons. Like when I was practicing, people were not that interested in practicing medicine. I was the first board certified anesthesiologist in Paducah. The same way, medical staff, less than 50% were board certified in their own specialty. Now, the more recent statistics show that 90% are board certified. This is the times of change. So you can't ask somebody who completed their residency in 1980 and go and take their primary board again, which is impossible and extremely difficult. For those, we are offering this so you can show that you are competent, you are keeping up with the knowledge, and you are technically competent also through this. So primary specialties considered for this are anesthesia, PMR, neurology, orthopedics, family medicine, radiology. Neurosurgery is there too. I don't know how, somehow I missed, but majority of them are, other than orthopedics, have subspecialty of pain medicine, all of them. Only orthopedics does not have subspecialty of pain medicine. Next is they have to have fellowship in an ACA-GME accredited or non-accredited ACA-GME program, or 3 years of full-time teaching and or practice in interventional pain management. Also 60 hours of continuing medical education, of which 30 hours is cadaver experience with satisfactory application. Of course, you need to have license to practice medicine. Didactics and cadavers are separate. Again, you have to complete these satisfactorily. Eligibility for competency. Regenerative medicine, we are not talking about that today, but you can be any of these above specialties. Again, unrestricted license to practice medicine, 60 hours of continuing medical education with 30 hours of hands-on work experience. The important one for today's topic is controlled substance management. This is very similar to coding, compliance, and practice management. So only thing you need to have is unrestricted license to practice medicine. This also applies to non-physicians, unrestricted license in whatever the specialty they are, a nurse practitioner, PA, physical therapist, even nurses. They can all be interested in it and take the examinations. It may be difficult to some of them, but generally you can get certified with a certification for associate certification. Examination process consists of basic science and core concepts involving 5%, pharmacology 25%, overview of clinical use and effectiveness 25%, overview of abuse 25%. You see, we have given a lot of importance to abuse and clinical effectiveness. Miscellaneous, including COVID-19 issues. So we had to revise some of the questions to accommodate COVID-19 issues. They will be limited to at the most 10% and probably 5%. Then there is the coding compliance and practice management. We did this last time. For those who are taking ABIPP path, both are important. This is a 2-hour examination with only 100 questions. So you have divided by 2. Everything is reduced. Whereas if you are taking the regular examination, you have to go through the other one. Diplomate process is, again, it is a written examination for 4 hours, or if you already have ABMS pain medicine, you don't need any of those things, written examination. What all you need is a single examination or separate examination, the one I was just showing you for PATH, of CSM and CCPM. This is 4 hours together. Part 2 is technical competency, oral plus practical, about 4 hours. If you were certified by FIPP, Reciprocity ended long time ago. ABIPP Part 1 curriculum includes anatomy, physiology, pharmacology, psychology, assessment of pain, diagnostic testing, pain syndromes, interventional techniques, non-interventional techniques of pain medicine. So these are the separate topics we have compared to ABMS. They do not have a separate section for interventional techniques. They do not have coding compliance and practice management. They do not have controlled substance management. That is the reason why we had to give a separate examination for this. ABIPP Part 2, oral examination is 1.5 hours, competency evaluation 2.5 hours with technical competency, safety, management of complications. IPM competency is only one examination. Again, don't get confused with board certification and competency examination. If you are taking board certification, you cannot take all of them on the same day, except those who are already certified by ABMS board, so they can take the path 2 and also appear for oral examination. But if you are taking part 1, this alternate pathway, you won't be able to take the examination the same weekend unless we are going to go ahead and give these examinations at separate times. Good news, we are really considering providing these examinations by Zoom, just like this. So we are looking into the process and difficulties we will have, pitfalls, and we all know the advantages, but these are the ones we are looking at. So here, one examination, it is given one weekend, written, oral, technical competency. But if we separate these examinations, it can be given by other means. Even oral examination can be conducted by Zoom. Regenerative medicine competency examination also the same way as the above. So what is next? How do I prepare for ABIPP examination? That is a major question. I always try to tell everyone that if you fail to prepare, you are preparing to fail. That is what John Wooden said long time ago. That's why our purpose is, it is a 2-day intensive course, as Amol said. Again, it will help you to pass CSM examination for Path 2 or ABIPP Part 1. This is the other organization we are talking about. You can get associate certification in controlled substance management expert, CSME. This is for all non-physicians. The first one can, controlled substance CSM certification can be awarded to all physicians, any physician. This is all for non-physicians. It is just a comprehensive review, refreshing for several others. So you have study materials enclosed for you, lecture outlines, questions and answers, other resources. One of them is the Foundation of Interventional Pain Management, one of our books in series of 3. Then there is a questionnaire on bone medicine, pain medicine and interventional pain management, board review, self-assessment. That is also one of the 3 series. After that, you really have a large publication on ASIPP guidelines for responsible, safe, and effective prescription of opioids for chronic pain, for chronic non-cancer pain. It was published in 2017. This is a very long document, about 200 pages or so, with extensive references. That can be very resourceful. And then you also have 2 other articles published in the same journal. But more importantly, you have CDC guidelines for prescribing opioids for chronic pain. We will talk about the advantages, disadvantages later, but if you are looking for references, looking for side effects and many things, it is a very great document to look at. There is Principles of Addiction Medicine. And again, one of our members, Peter Statz, was former president, and Stan Silverman, he will be talking today. They published a book on controlled substance management in chronic pain. Competency questions. There are 95 best answer with 4 choices. 5 or less accept questions. Now, when you are taking path, they are cut by 1/2. 100 questions, 2 hours. So choose the best answer of 4 possible responses. If a patient brings unused controlled substances back to you at your office, you should do which of the following? Flush the stuff down the toilet. It depends on regulations of State Board of Medical Licensure. Dispose of the controlled substances after the patient leaves your office and write down what you did in the medical record. Inventory the returned controlled substances and use them with other patients who cannot afford to pay for prescriptions for those drugs because they do not have health insurance. I just didn't say that you can administer to yourself, but that is also a possibility. The answer is B. Flush the stuff down the toilet may be accurate in presence of a witness, but your state regulations may be different than Ohio is different from Kentucky and New York is different from New Jersey. So you have to look at your state regulations, and that is how you dispose them off. In order for a prescription to be valid under federal and state law, it must be issued with the proper date and physician's signature to a patient who does not have a criminal history, only by a licensed physician and not by a mid-level practitioner. With the proper date, patient information, drug identification, and instructions for use, physician signature, and it must be issued for a legitimate medical purpose within the usual course of professional practice. I'm sure all of you realized that all first 3 answers are wrong. 4th is the correct one. Thank you.